Hello, everyone. I hope everybody can hear me okay. You're all very welcome to this evening's event. We're delighted to see so many of you joining us tonight for what we hope will be a really informative session on evidence-based treatments for adults experiencing an eating disorder. So my name's Sinead. I'm the Communications Manager here at St. Patrick's Mental Health Services. And before I hand you over to tonight's speakers, I'm just going to give a really quick intro into this evening's event. So you may know that this week marks Eating Disorders Awareness Week, and this week really is about raising awareness and tackling misunderstandings that can often surround eating disorders. So it's a really important opportunity to be able to host a public information event and to share some learnings on that. So we're really delighted to be able to host the webinar this evening. As I mentioned, the webinar will focus specifically on adults experiencing an eating disorder and the evidence-based treatments for some of those eating disorders. So over the course of the next hour or so, we'll hear from some of the multidisciplinary team here at the Eating Disorders Unit at St. Patrick's Mental Health Services. That includes consultant psychiatrist Dr. Claire O'Toole, advanced nurse practitioner Dr. Tony O'Connor, clinical psychologist Dr. Fionnuala McInerney, psychiatry registrar Dr. Aoife Gordon, and cognitive behavioural therapist Leah Hargadon. Following the presentations as well, we are hoping to have time for a Q&A session. So if you do have any questions throughout the webinar, you can submit them using the Q&A function at the bottom of your screens, and we'll try and get through as many of those as possible with the time that we have. For anybody then who has accessibility requirements, you can turn on closed captions by clicking on the live transcript function in your Zoom window. If you've any issues accessing that, just pop us a message on the chat function or the Q&A and we'll try and sort that out for you as well. And then also just to flag, it's an online event, so there may be some technical glitches. Obviously, we're hoping we get through it without a hitch, but if we do have any connectivity issues, some of our speakers may just need to turn off their videos, but you'll still be able to see the presentation and hear them. I am conscious as well that everybody attending this evening is probably very busy. So if you do need to drop off early, we just wanted to let you know that we are recording this evening's event, and that link will be made available to attendees in the coming days. Our speakers tonight as well, they will be covering a lot of topics. So of course, if you need to take a comfort break at any point, please do feel free, and the recording will be available if there's anything that you do want to go back on. So that's it from me, and we'll get started with tonight's first speaker, who's Dr. Tony O'Connor. And I just wanted to say as well, thanks so much to Dr. O'Connor and all of our other speakers this evening for their time. And I'll hand over to you now, Tony.
Thank you very much for that introduction. And good evening to everybody, and thank you so much for joining us for this webinar, which will focus on evidence-based treatments for adults experiencing an eating disorder. Now, there are probably many reasons why you've joined us tonight, be it that you're experiencing an eating disorder yourself, or you're concerned about a loved one that has an eating disorder, or indeed you might be a professional that's working with people with eating disorders. So we really appreciate that you've taken the time, and for some of you, the courage to join us tonight. So we're going to present 5 different interventions, and unfortunately, given our time constraints, we're kind of limited in terms of the amount of detail we can provide on each of the interventions. But really what we hope to do is give you an idea and a sense of what those treatments look like and what they have to offer. So some of you may already be familiar with some of the information we're giving tonight, but bear with us because we really want to make sure that people who aren't quite so familiar will get the information that they need. So we will go with the first slide, please. So the 5 different areas we're going to cover is the Maudsley anorexia nervosa treatment for adults, which is MANTRA, compassion-focused therapy for eating disorders, which is known as CFTE, specialist supportive clinical management, which is SSCME, and enhanced cognitive behavioural therapy for eating disorders, CBTE. And then we'll finally finish with medical management. Next slide, please. So first of all, I want to start by explaining what we mean by evidence-based practice. So I suppose traditionally, this was very much based on research findings, but more recently, it's been thought of as this 3-legged stool, which goes beyond clinical research to include service users' preferences and clinical experiences. Then in terms of international best practice guidelines, they come from a lot of countries. So we're really talking about like the UK, USA, Australia, New Zealand, Germany, Netherlands, and so on. And though there are some differences in the recommendations across the various guidelines, psychotherapy is deemed to be a central part of that treatment. So what I have done, though, is I've just mentioned there that some of the recommendations suggest a person is medically or nutritionally stable if they want to get the treatment to be as effective as possible. And then there are other recommendations that suggest medication alongside psychotherapy can really help to support the person in their recovery. Next slide, please. So the first treatment I'm going to talk about is Mantra, which is the Maudsley model of anorexia nervosa for treatment for adults. And this is a relatively new treatment, which was first recommended in the UK, which are called the NICE guidelines in 2017. Next slide, please. So in line with our thinking on what evidence-based treatment is, Mantra includes all three legs of the stool. So it's been developed with theory and research in mind, service users' preferences, and clinical experience. And those three things have become the foundation on which Mantra has been developed. So in terms of cognitive interpersonal, what I mean by that is that the therapy considers both a person's thoughts and their relationship with others in the world in the context of their anorexia nervosa. So the initial aim is to help the person to identify what's keeping anorexia nervosa going in their lives. So the treatment is workbook-based, and the workbook is used both in the sessions and for working at home with at a pace that's suitable for the person. And they can also include then close up others if they want. So we start really, the first part of the Mantra work starts with a person's motivational level and their wish to change their behaviors and step onto that sort of recovery road. Next slide, please. So this is a really interesting way of looking at motivation, because I think you might expect if somebody's coming for treatment, they're motivated to be well, but there's a distinct difference really between wanting to change and the ability to change. And I think really that kind of applies to everybody in every sense of the word. So if you think of somebody, and you might indeed be yourself a smoker, so if you want to give up smoking, you really want to change and you really want to do it. You know why you shouldn't be doing it. You know that it's bad for your health, that it costs a lot of money, all the sort of negative things that go with smoking. But when it actually comes to giving up smoking, the ability to change, something gets in the way, and it's a really difficult thing to do. Now, if we compare that to anorexia, I'm really only comparing the process of wanting to change and ability to change. Obviously, it's a lot more severe around the anorexia than smoking. So you will have somebody coming to you who would really want to change, and they might mark on this, maybe I want to change a 6, maybe even 5 sometimes, because often 10 doesn't kind of get marked when they start treatment first. So they're sort of curious and they want to think about what change might look like. But when we look at ability to change, more often than not, somebody will mark themselves maybe 2 or 3. And that's really the key to the starting point for Mantra work. We're going to look at what gets in the way of their ability to change and what is keeping them stuck. So we then begin to kind of think about the different focus areas that somebody can think about in terms of what's keeping them stuck. So if you could do the next one, please. Thank you. So the first point. So if we think of what kind of gets in the way, a lot of people with anorexia nervosa have this particular type of thinking style. So it's inflexible thinking, perfectionism, fear of making mistakes, and detailed focus. So that's really at the expense of seeing the bigger picture of life. Now, we might say, or you out there might even say, I'm a perfectionistic, I'm really afraid of making mistakes. But this is really significant for people with anorexia, and it very much stops them from being able to move on. But they need to be high achieving, all of that sort of thing. So that's a very tricky mind for somebody with anorexia to have. The next point, please. So they also then can struggle with experiencing emotions or connecting to others in an emotional way. And I suppose as human beings, belonging is really important to how we experience the world. And I suppose if you're thinking about this kind of avoidant of emotions, if there's something very distressing going on in a person's life, very often somebody with anorexia will tell us, I think about food and weight 24 hours a day, 7 days a week. It really kind of helps them stopping linking with their emotions and thinking what's going on for them and what difficulties are actually happening in their life at that given time. Next point, please. So when I write about the value of anorexia, I'm sure some of you are thinking, well, there isn't a value to anorexia, but believe it or not, it can actually benefit people in a lot of ways. And again, kind of giving them a sense of control, be it around eating and weight, or it might help them communicate to other people that they're distressed. So if you think about something like anorexia, it's a very visible illness, and it's really kind of saying, I'm not okay. Maybe it's because they don't have the words to be able to say that, or maybe they feel people won't hear them, but it's a very visible way of saying, I am not okay. And again, of course, the value of anorexia, as I've spoken about a minute ago, those sort of avoidance of emotions, it allows them to kind of be nearly, if you want to put it in another world that hasn't got emotions attached to it. So the next slide, please. So in terms of response from close others, I suppose a lot of you probably tonight are living with somebody with an eating disorder, and the effect of living with that person can determine kind of how you interact with them on a daily basis. So you can become overprotective because you're afraid something, you know, will happen to them in terms of their health. You're treading on eggshells to avoid arguments or food refusal, or indeed some of you might become angry and criticize the person. And all of these kind of tend to reinforce the eating disorder's behaviors. And now I really want to be very clear. I'm not saying that family members and close others cause or make things worse, but it's more about how the person experiencing the eating disorder interprets or makes sense of these things that have been said or these interactions. So, for example, it can be really frustrating when a person won't eat at the table with the rest of the family. And understandably, in normal conditions, this kind of lead to critical comments from others, or giving out to them, or telling them to sit down, or telling them they must eat what everybody else is eating. The unfortunate thing is, you might have a child or a person living with you who doesn't have an eating disorder, and they're able to kind of brush that off, or, you know, get into a huff. But for somebody with an eating disorder, it tends to enhance their own personal feelings of self-hatred and shame. And Dr. McHenry is going to be talking about those particular emotions in a couple of minutes. So what happens then when they have that sort of self-hatred and shame, they become more self-punishing and feel non-deserving of food. And of course, hence the eating disorder behaviors of restriction is reinforced. Next point, please. And again, Dr. McHenry is going to talk about that self-compassionate part, but there is a huge element of that in the mantra treatment in order to kind of help them link these sort of areas of focus with behaviors and moving forward with recovery. Thank you. Next slide, please. So this is a visual way of looking at what might be keeping anorexia going. So I'm sure you're all looking at that, trying desperately to make out what exactly does this mean. So this is what mantra calls the vicious flower of anorexia nervosa. So what tends to happen is we've looked at all of these areas, like the valued nature of anorexia, how others keep anorexia going, difficult emotions, so on and so forth. And we kind of tend to fill in this flower, and it gives the person a sense of how difficult the problem is, how intricate and how complex it is, because usually what happens is there isn't going to be one area of focus, but you're going to get those areas of focus linking with each other. And so you have this big mishmash of a map. But what's really useful about this flower is it makes sense to them why recovery is not easy. And often we would suggest that people would share this with their family or their support people, because it also allows support people to see how difficult this is, how complex it is. It isn't just a matter of eating. It's not just a matter of putting on weight, but you've got all of these underlying things that make recovery really, really difficult for the person. Next slide, please. So just in terms of the structure, what we're looking at is 20 to 30 individual sessions, and this will really depend, the amount of sessions will depend on, I suppose, the severity of the illness, the length of time somebody has the illness, or even their level of motivation. 2 carers are included in the session, and indeed more if this is needed. There's up to 4 sessions with a dietitian, and then the 4 follow-up sessions can happen maybe every month or every 2 months, and that's really just to check in and see how things are going, or maybe just to revisit 1 or 2 things that might have kind of been forgotten. So when they start, first you're looking at weekly intervention, and maybe after 10 weeks or so, depending on how a person is going, it moves to fortnightly, and then thereafter kind of monthly for those 4 follow-up sessions. Next slide, please. So this is the final slide in this particular part of the talk, and you're looking at the strengths of mantra. So it's an early intervention tool. It can be used at any time that somebody presents for treatment. It allows for the involvement of support people if the person wants. So it's very much kind of led by them what they want to do. The manual can provide evidence of progress, so the person can refer back to it. If they've moved on to other sections of it, they can keep going back to the parts that maybe they need to remind themselves of. So they have that workbook. So even though I might work with somebody using mantra manual, they actually keep the mantra manual themselves and bring it home. I don't own that. It's a really flexible way of working with somebody. So you're looking at a stage of recovery. So you might have somebody who has a long-standing eating disorder, who is only beginning treatment, or you might indeed have somebody who is short-term, and they need kind of to think about what their eating disorder means for them and what it is that is keeping it going. The level of motivation, again, I'm kind of going back to that part, is really important. So, you know, generally speaking, we would talk about 4 weeks of working on motivation, but in reality, actually, motivation work can actually go on for about 8 weeks. And sometimes, and I'm sure any of you who kind of live with somebody or you have an eating disorder, motivation can drop off. So somebody might be doing really well and going through the different focus area and working well on that, and then something gets in the way and their motivation drops off. It might even be a mood thing. So the flexibility allows us to park where we've been working and go back and revisit the motivational part. And then it can be used alongside other interventions, particularly group work. It's really helpful to kind of have that individual piece for somebody if they're engaging in group work as well. The people who do this piece of work find it really easy to engage with it because you're working at their pace. You are not asking them to change. And I think this is really important to think about. What you're doing is asking them to be curious about change and just to think about what that might look like and to choose the level of change they want to engage. So it's very much up to that person what it is that they want to achieve from the mantra. So this is just a snippet from one of the service users who was attending me. Sorry, I have to X this because I got to read it. There's something in my way. Okay, so it's I like having the knowledge about what anorexia means to me. It's good to understand more about my anorexia and have the knowledge. And this is really important because I'm still wavering. So this person might have gone through a fair amount of treatment, but they're still wavering. And that's the importance of that motivation and the flexibility in going over and back. Next slide, please. So I'm going to hand over now to Dr. McHenry, and she's going to talk about compassion-focused therapy for eating disorders. So thank you for that.
Hi, thank you. Thanks, Dr. O'Connor. And as Tony mentioned, I am going to speak about compassion-focused therapy for eating disorders. And I will just refer to it as CFTE just for while I speak. And it's been a model it's an evidence-based treatment that was developed by Dr. Ken Goss, who has published several papers on this, several chapters, and a book also in this area. And it's an intervention we also deliver here in St. Patrick's in a group format for outpatients. So I'm going to talk to you a little bit, give an overview around compassion-focused therapy, focusing on what the C in CFTE means, and just get a sense of what the intervention looks like here. So I might ask you to go to the next slide, please. So compassion-focused therapy was specifically designed originally for individuals with high shame and self-criticism. And as Tony was alluding to as well, that really self-hatred voice or self-directed hostility. And we know from the research that shame and self-criticism contribute to not only the development, the maintenance, and relapse amongst individuals with eating difficulties. And the research would also tell us that the levels of shame are higher in ED or eating disordered populations than any other clinical groups, with these individuals also reporting a really strong self-critical voice. And when we think about shame, I guess shame is it's a multifaceted concept. It's a very social and self-conscious experience. So often for the individual with an eating disorder, shame impacts on how they see themselves and how they think other people see them. So it's often that they see themselves as less than or inferior in relation to other people. Shame can also be triggered in different ways for the individual. They can be triggered by shame memories or past experiences. There's also the sense of how society shames us and thinking that we need to look or appear a certain way, or ideas of what shape and size we should be. And also relapse triggers shame. But not only that, it's also the eating disorder behavior itself can be actually quite shameful for the individual if the individual is binging or purging or restricting. So that can trigger shame. So you can imagine if even the eating disorder behavior itself is triggering shame, that is going to impact on the individual actually seeking support or seeking treatment. And not only is that happening, but also there's this self-critical, this really hostile voice in their mind saying that there's something wrong with them, that this is all their fault, and that they should be able to figure it out on their own. And this is why compassion is important. So I might ask you to go to the next slide. Because compassion is seen as the antidote to shame and self-criticism. And we know from the research, if an individual can learn to be more self-compassionate, they can significantly reduce levels of shame and self-criticism, which can lead to significant change in behavior. Now, I know in popular culture, the term compassion is often equated with the word kindness, or be good to yourself, or be nice to yourself. But in CFT, it's again, another multifaceted construct. And for in CFTE, the definition, like it's there on your screen, the definition is about showing a sensitivity to suffering, in your own suffering and suffering of others. And the second part is having that deep commitment to try to prevent and alleviate that suffering. I guess to say it another way, what compassion is, can I turn towards and pay attention and look at and understand the painful things in my life, including the eating disorder. And then in understanding it and exploring it and making sense of it, then make meaningful change. For the individual with an eating disorder, they often experience distress. They often end up criticizing themselves for it. And understandably, they want to avoid distress. And then quite often the eating disorder comes in as a way to cope and manage distress. So in CFT, we understand eating disorder behaviors as ways the person has developed to manage or to cope with distress, or to cope with difficult or challenging life events or experience that have even happened, either that they're happening now or that have happened in the past. So the eating disorder is an understandable response to life's difficulties. And a lot of our work in CFT is understanding that so much of what has happened to us is not our fault, but that self-critical voice can be really strong and really harsh in leading the individual to believe that it is. So the thing about this definition is, if we look at it, the first half is talking about bringing sensitivity to pain, to the suffering, to the causes and conditions related to the eating disorder. And the second half kind of looks at, well, how do I fix it? And naturally, individuals want the fix. They want the behavior to stop now, or our families and loved ones want the behavior to stop now. But we need to slow things down and first to understand what is going on behind the eating disordered behavior. But it is painful work. It's hard going towards our suffering because it is painful. So in CFTE, we work on ways on developing a range of interdependent competencies and attributes that I'll show on the next slide, if you don't mind going to the next slide, please. So we work on developing, I know this is a bit of a busy slide, but developing these competencies and attributes that help individuals work with the distress that they've experienced in life, work with the distress of dealing or managing with an eating disorder, and find new ways of coping that are helpful and not harmful to them. So if you look at the yellow, the yellow interior of the circle there, what we're doing in CFT is developing these attributes to be able to deal with distress, to be able to go towards our pain, to be able to go towards understanding the eating disorder and its function. And for that, we support individuals in the group, and the group support each other in developing the capacity to tolerate distress, to stay with sadness, to stay with upset, to stay with frustration, to stay with understanding difficult areas in their lives. It's also about developing empathy, sensitivity, and a non-judgmental approach rather than a self-critical attacking approach to their own difficulties. But that's just one part. It's like you go to the doctor and you've got a broken leg, and yes, you'd like him to be nice and sensitive, but you also need him to do something. And that's the blue circle. This is about, it's the how-to of the skills that we work with individuals to develop. And in using these skills, they can make changes to their eating behaviors. So CFT uses a lot of imagery practices to try and help the individual to develop their own compassionate mind that is wise and that will lead them to act in helpful ways. We also work on developing the compassionate mind in terms of our thinking and reasoning. So that compassionate view, the compassionate voice, and also how to learn to direct attention compassionately, so that we're moving that attention away maybe from the focus that the eating disorder preoccupation might have on size or shape. And we also work on developing skills to, like working on the sensory aspects as well, where we're gently and slowly supporting individuals to turn towards their body, where they begin to experience their body as helpful, and get a sense of a bodily experience of compassion, of that deep care and commitment for themselves and for others. And we also work on experiments on doing it in compassionate behavior. And a lot of this might be learning how to use one person, use their voice, but also how to seek support. So individuals in the group are learning to develop their own sense of courage, their own sense of strength and wisdom, and that commitment to make change. And naturally, there's going to be so many blocks to this, so many fears around change. And we work with those in group and work in ways, taking small steps to make change so individuals don't feel overwhelmed, and that they also get a sense of agency in the changes that they want to make. So I might ask you to move to the next slide, please. So just to give very briefly of what CFT looks like in our service, is the duration of the group is approximately 8 months long. It's weekly group sessions with some individual reviews as well throughout. It is a group for all types of eating disorders and people struggling with disordered eating. We often begin with a day and some work on psychoeducation, which provides mainly factual information about eating disorders and the way our bodies work. We spend a lot of time in group developing a compassionate understanding of how the ED developed and how it is maintained, how it keeps going. But we're also developing new compassionate coping skills. Again, often the eating disorder, the disordered eating has presented as a way to cope with distress, to cope with difficult scenarios in our life. And what the group is developing new ways of coping, because often the individual feels that it's either their internal world, like their thoughts, feelings, their emotions, and the external world are threatening places to be. So we work on developing using imagery and breathing practices, skills to help individual ground and regulate their biology so they can access their own innate wisdom and use the wisdom of the group as well. It's the CFT is both a psychological and a biological treatment. So working with individuals to bring these new coping skills online, then the group works together to support behavior change. So that means working towards normal eating. It's working on meal plans. It's working on how do we plan reducing eating disordered or disordered eating behaviors. How do we work towards stabilizing weight? And of course, managing relapse with that. And again, the normal part, or not the normal part, but a huge part of this work is working with the fears and the blocks around that, the things that get in the way of making change, understanding them and understanding what emotion or motivational drivers are blocking the individual from change as well. It is a group treatment, which is important if we consider shame, because shame really is very disconnecting emotion. It isolates us and makes us want to hide or avoid or shut down. So the idea of coming together to work in a group is a good way for individuals. It's quite de-shaming, but it's also the opportunity to start building up social connections, which can give them motivation to create and explore new social interests outside of the group as well. And I might ask you to move to the next slide, please, because this is incredibly important, because compassion it's not all about suffering. Compassion and CFTE wants the individual to grow and to flourish, to move beyond the identity that might be associated with an eating disorder. In CFTE, we talk a lot about our drive system, which is your system that gives you pleasure, excitement, joy, vitality, where you get a buzz out of life, of friendships, out of doing things. But often with individuals with an eating disorder, their lives have become so small and so devoid of pleasure and joy, and their only sense of pride might be from losing weight or sticking to the diet plan. So in the group, we're working with individuals and moving from this place of threat, or a place where they're comparing themselves negatively to other people, to more compassionate mindset, which is focused on wanting the best for themselves and for others, and to take delight in who they are and to take risks in life, to garner greater understanding of their own sense of self, of who they are and what they want to be without the eating disorder. So that's a really quick overview, and please do contact us if you'd like more information around CFT for either for yourself or for a loved one, and we'll be happy to chat about it. But I might go to the next slide, because I'm going to pass you on to my lovely colleague, Dr. Claire O'Toole, who's a psychiatrist as well on the team. Thank you.
Thank you. So thanks for that introduction, and thank you everybody for joining in with us this evening. So to date, you have heard from Dr. O'Connor about Mantra, which is an evidence-based treatment for anorexia nervosa, and you've heard there from Dr. McInerney around CFTE, which is evidence-based around the various eating disorder diagnoses. So I'm going to talk about specialist supportive clinical management, which is a evidence-based treatment for anorexia nervosa. Next slide. So I'm going to refer to it as SSCM. It is basically a combination of clinical management and a supportive therapeutic style. And originally it was actually designed as a comparative or control treatment in a research project, whereby it was designed to be the control against two other interventions, where the therapist had expertise in eating disorders and was to provide good quality clinical care with a theory to see if the other treatments would be superior to the control of SSCM. And very interestingly and surprisingly, they found that actually the SSEM itself was superior in the initial outcomes, which was actually a surprise and not what the researchers had been expecting to find. Next slide. So it has two overarching components: clinical management, which involves normalizing eating patterns, encouraging the patient towards weight gain and weight restoration, addressing other aspects of eating disorder behaviors and effects. There's a substantial component of psychoeducation and supporting engagement and adherence. The other component then is the supportive therapy aspect, and this focuses very much on the life issues and the important issues raised by the person themselves. The style of the therapist is empathic, supportive. It involves an active listening style, open questioning, reflection, and praise. Next slide. It is a manualized therapy for adults with anorexia nervosa, and it constitutes 6 unique features. So it's very much patient-centered, non-prescriptive. It draws on the person's own strengths and their values. It is very much inclusive of both those two components we referred to earlier, the supportive psychotherapy and then the problem or the clinical management, looking at target symptoms, which we'll talk about in a moment. It involves very much a kind of a flexible and a responsive therapy style that can be employed by a variety of clinicians with expertise in treating anorexia nervosa. With it, there is a commitment to reversing the starvation through a directional approach. And by directional, we mean moving the person gently towards change, very much in the person-centered, person-led way. There's very much a defined yet a flexible approach on dietetic intervention and a commitment to the therapeutic process. Next slide. Now, this is a busy looking slide here, but it is essentially a conceptualization of SSEM as outlined by Laura Kiley in her 2022 paper. And you will see here with this, I suppose, up at the top, you will see the risk factors for developing an eating disorder, including family factors such as history of eating disorder, depression, alcohol, traumas, societal issues, personal issues to the patient, you know, similar to what Dr. O'Connor referred to earlier. The person may have their own difficulty with problem-solving skills or issues around self-esteem or that kind of highly perfectionistic personality style. And here you will see in the center the two main strands. So the clinical management aspect is very much the disorder-focused part, and then the supportive psychotherapy being the person-focused aspect. And you will see that this treatment is very much embedded in broader supports. So, you know, alongside the intervention, there is often ongoing the psychiatric, the GP attendance, dietetic support to assist the individual. Again, as you'll see with the other therapies, that, you know, the course, the duration, the number of sessions involved in a course of treatment is quite lengthy. And you can see there anything from, you know, 20 to 40 sessions onwards. And there are 3 key phases: engagement, treatment, and termination and beyond, which I'll talk about in a moment. Next slide. So the first phase there is engagement, and this aspect will often involve assessment and psychoeducation. In this aspect of treatment, very much the therapist is quite active and highly involved in helping look at identifying these target symptoms that the person is going to work on. And these target symptoms can include anything from dietary restriction, purging behaviors, excessive exercise, laxative use, excessive fluid intake, social withdrawal, difficulty eating with others, low mood. And these target symptoms then are worked on through the treatment phase, and typically a session will start with the first part, the therapist focusing on these target symptoms, looking at any changes in eating and weight restoration. And then the second component will be more open to the patient to raise issues that are central to them. And then phase 3 looks at the ending and the finishing termination of therapy, planning for the future, looking at maintenance, looking at relapse prevention. Next slide. Who may benefit from it? Adults with a diagnosis of anorexia nervosa, typically people who want a more flexible approach where they have freedom to create their own agenda and discuss issues that they are already aware of and cognizant of. It may be useful in those who've perhaps engaged already with other therapeutic approaches but have not had success with them. People who may be less motivated to engage in an active therapeutic process, or people who want to work maybe more slowly towards progress rather than achieving full recovery. Next slide. This is just, I suppose, referencing that there is a substantive evidence base for SSCM as a viable and efficacious intervention. There are quite a number of randomized controlled trials. So these are our highest level of evidence base, where the study design randomly assigns people either to the experiment group or the control group, the only difference between the groups being the treatment offered. And it has proved to be a very good treatment in these studies. I suppose it's important to say that what you're hearing about today or this evening are a number of different interventions. And broadly speaking, you know, they have equivalent evidence bases around them, but there may be different individual aspects that might make one treatment more suitable for a particular individual, or it may be around accessibility to a treatment, etc. There has also been a trial of SSCM modified for those with a more long-term eating disorder, severe and enduring anorexia nervosa. And this approach is adapted to very much focus on quality of life improvements as opposed to mandatory weight gain. Next slide. How does it differ from the other therapies? I suppose in contrast to MANTRA, which Dr. O'Connor talked about earlier, whereby the treatment was developed based on all the research and knowledge that we have. In another way, the SSCM came about almost by accident, in that it was designed as a control, not as a treatment. It is non-prescriptive, it's non-directive but directional, so getting the person, you know, gradually nudging in the right direction towards recovery. The session length and number are very much individualized and responsive to the participant's own needs, typically about 30 to 50 minutes per session. It doesn't involve homework, and it works with issues that are already known and named by the patient, unlike some other psychotherapeutic approaches. So I'm now going to hand over to Leah Hargaden to discuss enhanced CBT.
Thanks, Dr. Jill. Okay, I'm going to talk about enhanced cognitive behavioral therapy. Start the slides there, thanks. So I'm going to talk about why we might consider CBT for eating disorders, what is CBT more broadly, and then more specifically, what does CBT itself involve. Next slide there. So it's transdiagnostic. That's a big word, but essentially means it's suitable for all of the eating disorders. It's manualized to a degree, but it's also flexible. While there's protocols involved, they kind of set out what is to be done, but it's highly individualized and flexible within that way, and addresses the core maintaining factors that are very individual for the person. There's a focus on the here and now, unless a longer term perspective is deemed more useful or appropriate. Next slide, thanks. CBT, if I could talk a little bit about what we do in CBT and come back to what we do then more specifically in CBTE. The CBT model involves these 4 parts: the interaction between the thoughts, the physical sensations, emotions, and behaviors. We don't experience them all separately, we experience them initially together all as one. They're all interacting to create our full experience. I heard it described as like a wicker basket. Sorry, I thought it was a nice description where the strands are quite woven together. It's hard to notice each one individually. We just experience the basket as a whole. So we're trying to get practiced in CBT at breaking it down and understand what's going on for the person. And if we change one, the idea being that the other parts can change. For example, if we stopped eating, there will be physical sensations, things like low energy, physiological consequences. Thoughts then get more rigid, inflexible. Emotions become numbed, or the person experiences things like irritability or mood swings. And then what behavior can come from that? Things like social withdrawal, or indeed other eating disorder behaviors to try and manage emotions or other tricky things that might have come up for the person. So we do the basics first. When we think about CBT, we get the foundation, we get to know what's keeping the cycle going, or ultimately the person stuck. Next slide. So cognitive behavioral therapy, what is it? We talk about the cognitive piece being thoughts. Thoughts aren't facts. Thoughts are a mixture of opinions, judgments, stories, memories, interpretations, and even predictions about the future. And then the behavioural part of CBT, we talk about behavioural change for wider change. CBT is a doing therapy. We start with behavioural change and what that can involve, things like approach rather than avoid situations, facing the fears often in a graded way, exposure to eating certain foods, maybe eating in front of people, and things like behavioural experiments to acquire new information, such as that eating a certain food that has been off limits perhaps doesn't lead to catastrophic weight gain or a loss of control of eating. So in that way, it's not just the 1 hour a week at a session, it's the in-between session work is just as important for learning and growth to occur in these ways. Next slide. So, and what is CBTE? Sorry, this slide is a little bit fuzzier than I kind of hoped, but it was a helpful one to lay out the treatment map of what CBTE more specifically involves. It's 4 stages. The first one, starting off with things like psychoeducation. I know some of the other clinicians here have spoke about. There's a certain degree of ambivalence to be expected as well, which Dr. O'Connor had reflected on. And there's self-monitoring, which look at identifying triggers for the person depending on situations that might present. Going to establish regular eating and meal plans, all that in stage 1. Stage 2 is a 1 session stage actually, but that's just looking at what's been going well from stage 1, taking stock really, and looking at planning then for stage 3 and what to address in stage 3, which looks at the 3 areas outlined there: body image, dietary restraint and rules, and the events, moods, and how they are related to the person's eating. The body image stage is a key part really. It looks at things like body checking, body avoidance, comparing, and the overvaluation of shape and weight would be a really key part of what CBTE involves. So we can go on to the next slide there. And that's the key part. I want to look at that one for everybody. The overvaluation of shape, weight, and its control, and how that plays out, whether it be dieting, exercising, or low weight. And when we start off in CBT, we're developing a discrepancy for the person where these things might have started out as this helps me or these things help me. And as we get to that stage 3 that I've been talking about, there's a sense of realization that perhaps actually this harms me. And when we get to that we can actually work on the eating disorder then in a more meaningful way. Next slide then. Yeah, so it involves 20 to 40 sessions depending on things that are going on for the person. It's in 4 stages. As I said, the stage 4, sorry, I didn't look at, is aimed at maintaining the progress that the person has made, looking at other coping skills, and looking at ways to prevent relapse. And the key components, as I was saying there, of the work is on the overevaluation of shape, weight, and control for the person, with the option for broader work on what's known as broad CBTE, on things like perfectionism, low self-esteem, and interpersonal difficulties. Next slide. Okay, and to leave enough time for questions, before I hand over to Dr. Gordon, I might leave my final word on choice. So as emerging research developments increase our understanding of the onset and maintenance of eating disorders, treatment choices enable therapists and us as clinicians here today and the person to select the type of therapy approach most suited to their individual presentation of a disorder. Okay, so I'll hand over to Dr. Gordon. Thanks.
Hi, so I'm going to talk about the medical management of eating disorders. So firstly, I'm going to talk about anorexia nervosa, and then I'm going to speak about bulimia nervosa and binge eating disorder as well. So you can go on to the next slide, please. So I suppose just some general principles to think about. So the standard treatment for anorexia focuses on nutritional rehabilitation and psychotherapy. So medication is not, the primary treatment for anorexia nervosa. So it can be used as an add-on for in very specialist circumstances when people are very ill and they're having difficulty gaining weight with the usual nutritional rehabilitation and psychotherapy. So in addition, medication can also be used to reduce depressive symptoms and anxiety. So just to note that distorted thinking about body image and food does not usually, respond to medication, but it can be added into the treatment regime, but the focus of the treatment still needs to be nutritional rehabilitation and psychotherapy. So yeah, you can go on to the next slide, please. So before prescribing medications, clinicians are always going to be thinking about the medical complications of an illness like anorexia nervosa. So anorexia is a disorder that can affect the heart. So it can cause a very slow heart rate, low blood pressure, and problems with the rhythm of the heart as well. So these are medications that have an effect on the heart. So they're just something that need to be used very cautiously. So really in specialist services, there is limited evidence to suggest that a medication like olanzapine, which is an antipsychotic, can be useful in restoring weight, again, in combination with the standard treatment. There's side effects, so it can have effects on the heart. There can also be metabolic side effects. So it's a medication that, it's not kind of a first line treatment. Another medication that can be useful in kind of reducing anxiety around meal times is a medication called alprazolam. So it's commonly known as Xanax. So it could be used in there's some limited evidence that shows that it can be useful as a short-term medication in helping around meal times. There are side effects, so it has addictive properties, and also it can cause a lot of tiredness. So it is something that would be used in the short term. Yeah, you can go to the next slide. So thinking about treating other psychiatric disorders which can occur at the same time as anorexia really depends on the severity. So oftentimes you can see that standard treatment of anorexia, which would involve psychotherapy and increased nutrition, can actually help with some of the symptoms of depression and anxiety. However, there are cases where, for more severe forms of depression and anxiety, considering an SSRI medication can be useful. So that would be something like sertraline that could be used and is generally well tolerated. So we can go to the next slide. In thinking then about the medical complications of anorexia, so I'll just give a kind of a brief overview. in that anorexia can have medical effects on the body that can range from mild to severe and life-threatening. And there can be complications across all the systems of the body. So cardiac, metabolic, gastrointestinal, reproductive and bone health. So when a clinician is thinking about where someone with anorexia should be treated or how to treat someone with anorexia, you're always thinking about risk assessment. So, you know, what are the potential medical complications here, and what level of physical monitoring and psychiatric care will somebody need? Just to touch on the refeeding syndrome, which is when someone is having their nutrition restored, there can be shifts in fluid and electrolytes in the body, which can be very serious if they're not detected and treated early. So treatment in that case would involve kind of reevaluating the nutritional support and also correcting the electrolyte abnormalities. So you can go to the next slide. So thinking then about bulimia nervosa, so medications actually can be very effective in bulimia nervosa, and it can be used as a first-line treatment, again, in addition to nutrition and psychotherapy. So a medication that can be really useful is fluoxetine. So that's another type of SSRI medication that's usually used for anxiety and depression. And there's evidence to suggest that using a medication like fluoxetine in slightly higher doses than would be used typically in depression and anxiety can have a lot of benefits. So it can benefit in reducing the number of binges. It can reduce purging and some of the eating disorder thoughts as well. There other medications can be used like sertraline and escitalopram. So the thing with fluoxetine is it's usually would be used kind of up to 6 to 12 months after there's been a response. But that'll really vary for each patient. So depending on how long a person has had symptoms for, or how severe it's been in the past, or have they ever been admitted to hospital. These are all things you'd be thinking about. Again, just with medical complications of bulimia, so it can affect all the systems in the body again. So thinking about the cardiovascular system, there can be dehydration as a result of vomiting. There can be problems with reflux. So all of these medical complications need to be kind of risk assessed prior to with a doctor before looking at before kind of going any further with treatment. Yeah, you can go to the next slide. So then looking at the medical management of binge eating disorder. So for binge eating disorder, psychotherapy is usually used as a first line rather than medication. So if medication is to be used, again, an SSRI medication is generally well tolerated and can be very effective. And for medication in this case, the doses are usually around the same as would be used for depression, and sometimes greater as well. So that's from my point of view. So just if anybody has any questions, just feel free to put them into the chat function and we'll get back to you.
Thanks so much, Claire, Leah, Fionnuala, Aoife and Tony for that brilliant, really informative presentation. I don't know if I'll invite you all just to turn back on your cameras for a second, and we'll give people a chance to ask questions there. I can see that we have one in there. Why is fluoxetine effective for BN but not AN? What are the differences in etiology? So I don't know, Aoife, maybe if you wanted to take that one perhaps, or if there's somebody else that would take that one.
I don't know, maybe Dr. Gordon or Dr. O'Toole, if you want to, could you answer that?
Yeah, I mean, I'm not sure that we know exactly why one works over the other, but I suppose all we know is that there have been, multiple trials of, antidepressants in anorexia nervosa, and they haven't, I suppose, been shown to lead to beneficial outcomes. So I guess, you know, that's kind of where the evidence base is around them currently. And I know we're kind of constantly learning more and more about the etiology behind the conditions. And obviously, while there are a lot of parallels, there are some, I suppose, key differences as well.
Of course, yeah. There's another one there that says, what therapy would you suggest for avoidant restriction food intake disorder when the client or the patient doesn't want to gain weight?
There's a lot of good evidence actually for CBT for ARFID. It would take more of a behavioural approach in that way, and it would look at things like I was talking about with exposure in a graded way, depending on the type of food. It could be just on the person's plate, near them, all these kind of graded ways. So there's a lot of good research around CBT for ARFID.
Okay, thank you. I can see there's a question for Dr. McInerney as well, but I understand that she had to leave after her presentation. So we can just take note of that question and we can try and get an answer back to that attendee. There is a question there in relation to whether or not the same models are used in an adolescent service as would be used for an adult service. So I know obviously tonight we're focusing on treatment models for adults, but I suppose just on a quick yes or no, would those treatments be applicable to adolescents as well?
But they'd be adapted. They have to be adapted because obviously their thinking is different, the family involvement is different. So, but yes, they can be applied, a lot of the same models.
Right. Okay, we actually have a good lot of questions coming in there. So let me just have another look through here. So when someone is diagnosed with ASD, how would treatment be adapted to meet the patient's needs?
I suppose again, that's very much dependent on the person. There wouldn't be just one answer for that. Yeah. This would all be determined by assessment, like what level of functioning, how the SD is getting in the way, about family support. So really, that person would need to go for a full assessment if you were to think about what the appropriate interventions would be.
Okay. And then we have another one there about compassion-focused therapy. So just wondering if that's delivered online or in person.
It's in person.
In person.
Yeah.
Great. I think I can see there's a lot of comments and questions coming in there. We do have a record of it after, so if there's any pertinent questions or if anybody wants to follow up, they can email communications@stpatsmail.com and we can see if we can point you in the right direction. This question's come in, and actually it's something I've heard a lot today as well through radio interviews as well. So how would you approach someone who came to therapy with an eating disorder but didn't want to engage with their GP?
I mean, I can take that one, I suppose, to some extent. You know, again, it's what we talked about earlier, really, about, I suppose, you know, you're looking at somebody's kind of motivation to change. As a therapist, I would expect you probably have some kind of baseline, I suppose, you know, standards and criteria as well in terms of kind of keeping a person safe and somebody having a degree of medical stability. So you may have some, you know, I suppose, guidelines, you know, yourself as a therapist with, you know, what is expected, you know, that there would be, I suppose, expectations for, you know, what the person will contribute as part of your agreement to engage with them in a form of therapy. I don't know if anyone else wants to kind of add in there, or does that answer it?
Risk. It's about how risky that person might be in terms of their physical health, and that's really what you have to weigh up if you're providing treatment for somebody and if they're not going to their GP, because it's too difficult. You know, when somebody engages in therapy, sometimes things can get worse before they get better, and so sometimes eating disorder behaviors will actually escalate a little bit, so that puts them in a very kind of, I suppose, risky place if they're not being monitored by a GP. So again, I think as Dr. O'Toole is saying, it needs to be guided, I think, by the therapist and what they're willing to kind of work with.
And I suppose another key point that, you know, I was making earlier is that very often, you know, as we were saying, eating disorders are complex illnesses, and very often treatment will not be a standalone psychological intervention by itself. It would usually be part of a whole package of care that involves dietetic support, GP monitoring, psychiatrist, and so on. It's very rarely the therapy by itself without the whole package.
Okay, perfect. I think that hopefully answers that attendee's question. There's a question there as well just about the slides. So a recording of the webinar will be made available, and that will include the slides as part of the recording. So you'll see them on the recording screen. And I think we'll close it off there because I'm conscious we're going over the hour now, and I'm sure everybody's extremely busy. So I just wanted to thank everybody once again for attending this evening, and thanks again to all of our speakers for giving their time this evening. We hope you found it useful and informative. I mentioned this already about 2 seconds ago, but it's drilled into me at this point. The recording will be made available. So just keep an eye on your emails. If anybody who's registered will get a link to that over the next couple of days. And then finally, when we do sign off on this evening's webinar, you'll see a link on your screen where you can share feedback. So we'd really love to hear your thoughts about about your opinions on tonight's event. So if you do have 2 minutes, please do follow the link and share your feedback. It really helps us inform future events. So that's it then from us this evening. Thank you everybody again for your time and for your attention, and thanks again to our speakers. Have a good evening. Take care.